Let's start the meeting. Good evening, and thank you for joining today teleconference on COVID-19. And my name is Dr. Sudhakar Jonalagada. I'm a gastroenterologist and a transplant hepatologist. I'm the president-elect for American Association of Physicians of Indian Origin. You all know that we are passing through the dreaded condition pandemic with the COVID-19. As of today, a few minutes ago, there are 1.5 million cases have been confirmed with the disease, and about million cases of active disease, active cases. And so far, there are 328,000 patients recovered from the infection, and about 87,000 people have died so far. Okay? So we are really dealing with a very difficult disease, and we are learning day by day. And today we are looking for some new modalities how we are going to deal with this virus. And I want to thank you, Dr. Sagar Galwankar, who really put up this meeting today with other panelists. And with me today, the other moderators are Dr. Lokesh Idra and Dr. Binod Sinha. Dr. Lokesh Idra is an allergy immunologist from Michigan, and he actually is the one who initiated this telemeetings from the API point of view. And Dr. Binod Sinha is a practicing urologist in New Jersey. He's the president of New Jersey API. Let me start with the first speaker, Dr. Sagar Galwankar, who is also a symposium chair. Dr. Galwankar is the director of research in emergency medicine and Florida State University Emergency Room Residency Program at Sarasota Memorial Hospital, Florida. Dr. Sagar is going to speak on spectrum of emergent COVID presentations. Dr. Gagar, go ahead, please. Thank you.
Thank you very much, everybody. I hope everybody can hear me. So good evening, everybody. I'm very thankful to Dr. Sudhakar for calling upon the American College of Academic International Medicine, the INDUSIEM Health and Medicine Collaborative, as well as the World Academic Council of Emergency Medicine to host this meeting. All the leaders from these respective organizations are speaking, and the speakers you see today are all engaged in advancing academic health medicine across the world when it comes to research, education, and patient care. They're extremely well published, well known, and speak with a lot of knowledge with science and innovation. So I'm very thankful to Dr. Sudhakar to think outside the box to call real academicians to do this meeting. And taking this in mind, I'll be speaking on the topic on the spectrum of COVID presentations. Now, as we all know that COVID has got a lot of knowledge developing dynamically. So we all know it's a virus. We all know that it causes severe failure of multiple organs, and hence detecting it or suspecting it is very, very important. In our meetings, which have been going on since the start of the epidemic, when it became a pandemic, we realized a couple of things which are very, very important. First is there's no such thing as hotspots. So the concept that it really exists in certain areas and it doesn't is only there when you're trying to contain. Once it's out, it's a community spread. So we are looking at two situations on presentations. We are looking at presentations in the clinic, and we are looking at presentations in the emergency department. From our experience working internationally, as well as on the front lines of healthcare in emergency and critical care, as well as infectious disease and critical cardiology, geriatric medicine, we see that the presentations are not only pulmonary, but also extrapulmonary. So we have these two sets of combinations which are coming. The other important part when you look at presentations is how actively are you hunting for those symptoms. Patients may not sometimes tell you those symptoms directly. So understanding the syndrome and not relentlessly being, okay, everything is COVID, is not the correct way, but you got to hunt for the symptoms when it comes to the clinic as well as the emergency departments. The symptoms are pulmonary and extrapulmonary. So when you talk of pulmonary, anything from the throat to the lungs is fair game. When you talk of fever, cold, chest tightness in the throat, very important to look at the whole system, runny nose, fever. The extrapulmonary symptoms are more important because those are the symptoms which have to be hunted for. And those symptoms range from seizures, altered mental status, delirium, loss of smell, loss of taste, nausea, vomiting, diarrhea, chest discomfort, generalized myalgia. All these things present as the extrapulmonary symptoms. And there are the extrapulmonary symptoms found in laboratory suspicion, that is severe lymphopenia, hypokalemia, which are being found as one of the prognostic markers when we manage your patients. So when you're in the clinic, you got to actively hunt for these presentations. Now, when patients arrive in the hospital, they either come walking or they come by EMS. So we have these presentations from nursing homes where patients are deteriorating fast. And they don't know, and hence they send it over here, and then they start detecting. Because remember, there's no bedside test. It takes a little time for the test to come. So the presentation is very important. So your average altered mental status, average nausea, vomiting, diarrhea, and actively hunting for a history of fever. Another interesting point which has been found in our data set, we are running a huge data collection, big data analysis across the world from the hot zones in Italy, Spain, Japan, Malaysia, and Singapore. And our data, which we congregate every Saturday when we discuss things, we have come to realize an interesting feature, which also will be discussed in the triage lecture, is diagnosing silent hypoxia. That's very, very important. So when you look at silent hypoxia, you should be able to catch it. And there's something called as stress hypoxia. Dr. Sarkey is going to talk about that. So the presentations are varied, but looking out for them and really taking a correct history and understanding the core components, whether the patient has diabetes, high blood pressure, the patient has a heart attack, stroke, or cancer, does have any HIV, hepatitis B or hepatitis C, any asthma, any allergies, does the patient drink alcohol, smoke, or do drugs, does the patient have congestive heart failure, liver failure, kidney failure, has blood clots, very important because prothrombotic tendencies are seen in COVID, in the lungs or in the liver. Are they on anticoagulation? So these are, did they have seizures before? Do they have home oxygen? Are they COPD? Or are they immunocompromised? Are they on transplant? Are they on chemotherapy? So your general history has to go through this 40-line checklist, as well as symptoms like diabetes, high blood pressure, heart attack, stroke, cancer, HIV, hepatitis B, hepatitis C, asthma, allergy, drinking alcohol, smoking, doing drugs, congestive heart failure, liver failure, kidney. You got to go over that completely and then go over chest pain, shortness. And that's when you create the cluster to highly suspect whether these patients are going to be tested or not. History of travel is very important. Well, that's there. And also the patients who deteriorate. So in the lectures, following my lecture, you'll see the challenges at every level in the patient's journey from the clinic to the hospital, from diagnostic to triage to critical care, and how the other disciplines like complex cardiology, geriatrics, as well as surgery interact in this system. So the symposium starts off with my presentation on giving you a bird's eye view of how do you really approach a patient and look for pulmonary, extrapulmonary, and vital sign deficits of the syndrome of silent hypoxia. With this, I would like to transfer my continuation onto the next speaker so that when we take questions, we could answer more of these questions, more of these issues. So we'll take questions after the symposium, and I will give it back to Dr. Sudhakar to call upon the next speaker. Thank you very much.
Thank you, Sagar. Thank you very much for a nice presentation. The next speaker is Dr. Dhanasri Kelkar. She is internal medicine as well as the infectious disease specialist, and she is the chief editor of Journal of Global Infectious Disease at University of Florida and Winter Haven Hospital at Florida. And she's going to speak on Decisio diagnostic. And welcome, Dr. Kelkar.
Thank you so much, sir. I hope you can hear me clearly.
Mm-hmm. Yeah,
so
go ahead.
Okay. So in a few minutes, I will try to capitalize on what diagnostic dilemmas or decision dilemmas we face. And to make it short, make it easier, I will break it into question-wise testing, question-wise answers. So the number one question for any patient presenting is first is who to test. So depending upon if I will discuss two scenarios, one is the office and one is the hospital. So let me start with the office scenario first. So in the office-based scenario, you will there are 5 important points you will consider. Number 1 is the symptoms. Either the patient has an upper respiratory symptoms like sore throat or loss of smell, which has been complained of more and more by more number of population, or lower respiratory symptoms in the form of cough or shortness of breath, or if the patient has generalized symptoms like fevers, myalgias, generalized weakness. The next few things you need to confirm is whether this patient has had a contact with a positive patient or a suspected COVID patient. Nextly, whether the patient has risk factors like patient is immune suppressed, has comorbid illnesses, diabetes, hypertension, underlying lung problems. Next thing that you do need to consider is there some other diagnosis which could account for these symptoms? And lastly, your vital signs that you take in the office, including the saturation, whether you have any hypoxia. So if you have the symptoms and any of the other 4 points, you would consider this patient as a person under investigation in the office. Similarly, in the hospital scenario, other than the 5 things like the symptoms, the contact, risk factors, and vital signs that you would look at, you also do need to do other tests like X-ray. If it shows evidence of infiltrates, pneumonia, then that would be a supportive diagnosis, hypoxia. And if you have the time, you can do inflammatory markers, which may come back pretty rapidly in the ER in the form of a D-dimer or a procalcitonin, which is elevated, or LDH, which is elevated, or a procalcitonin, which is normal. So if you do have positive X-ray and symptoms, you also can consider this as a patient under investigation. So once you've defined which patients you need to test, you put these patients in isolation and make sure in the office you have enough isolation for these patients also. And then you would order tests. The tests which we have currently available are in 2-pronged predominantly. Number 1 is a PCR-based testing, and number 2, which the FDA has just approved as of 1st of April, is an antibody test. Which test to send would depend on what you have available in your office or in the hospital. Currently, most places have the PCR-based test, and the antibody-based tests are only available, will be made available shortly. In addition, now in the PCR-based test, you have the rapid tests like the CPID or Abbott test, which are one is a 45-minute test and one is a 5-minute test for a positive result, which can be used in a clinic-based or an urgent care-based test, or you have the RT-PCR-based. Now, RT-PCR is more cumbersome, and it can take anywhere between 24 hours, especially if you do it in your own hospital or your own the hospital-based chain lab. It would be less than 24 hours, but it can take as long as 3 to 5 days, sometimes even as much as 7 days, depending upon where you're sending it out at the lab. Now, the reason why hospitals prefer an RT-PCR at times is because they can run multiple number of tests at the same time. Whereas the rapid test, the Abbott and the CPID tests, which are easily available now, they have to run just one test at a time. So they are more easier to do in a clinic or an urgent care base where your patient load is not that higher. Now, for the PCR test, initially there was a thought that, okay, you could use throat swabs, oral swabs, nasopharyngeal swabs, but over a period of time, we have realized that the nasopharyngeal swab is considered the standard. Okay, a throat swab had less than 30% sensitivity. Nasopharyngeal swabs, the sensitivity is somewhere less than 90% right now. Sometimes in some studies, it has been as low as 60, and in some studies up to 90%. The sensitivity of this test also depends on how the test is done, how the swab is collected, and at what point of illness you are collecting the swab. Now, if you have, so this is as far as the testing goes. Now, for the PCR test. Now, antibody tests, which have just been approved, you have the IgM, IgG antibody test, and they currently show a 93 to 96% sensitivity, but they have to be done at least after 7 days of illness onset. Do we have any home kits available? No. There was talk that, okay, you can do home testing, and many companies have started coming up with these test kits, but currently nothing has been approved by the FDA. Other than the PCR test or the viral antigen test as well as the antibody test, you can do other supplemental testing in the form of elevated CRP, elevated ferritin, elevated high LDH or a D-dimer, and this can also support your illness. Now, what do we interpret with these tests? Okay, so if you have a positive test, yes, your patient has a COVID-19 related illness, and you would treat this patient as well as the contacts appropriately depending upon the clinical status. But what does it mean when you have a negative test? Now, if you have a negative test, yes, this may be a patient who does not have COVID, and patient's doing well, you can just have the patient self-isolate at home. But if you have a very high clinical suspicion and negative test, you can use other supportive tests to help base your diagnosis, what we spoke about, the CRP, ferritin, D-dimer. And you can retest this patient in the next few days or try to obtain lower respiratory specimen if you can. Again, you should not do a bronchoscopy just for testing purposes, but if you have access to low respiratory specimens, you can send that. Or after a period of 7 days, you can consider doing antibody testing. Now, there is another case scenario where patients have persistently tested positive. And so what we know is that they are excreting viral RNA. Does that mean that they are infectious? They have active virus in it, and can that virus be grown in culture? No, we have not tried that, so we don't know whether they are actually infectious or not infectious. But all we know that sometimes, even up to 25 days to 30 days, patients can still be persistently positive. And with this, I will come to an end with the testing, and we can take questions later on.
Thank you, Dr. Kelkar. Dr. Yedra, please go ahead and introduce the next speaker, please.
Okay. Thank you. This is Lokesh Idara. First, let me read the disclaimer. This symposium is for information purpose only, should not be considered as medical or a financial advice. API has no liability as to how this is interpreted or any results, losses, damage that may be caused directly or indirectly or incidentally. Please refer to CDC website or your state medical societies and state medical departments for up-to-date information. With that, I'm going to introduce next speaker, Dr. Sarathi Kalra, Director of Research in Emergency Medicine, University of South Alabama, Mobile, Alabama, USA, on the topic of trends in clinical triaging. Thank you. Dr. Sarathi.
Hello. Thank you very much. My name is Sarathi Kalra, and I am going to be talking about the trends in clinical triaging. So, as Sagar and Dr. Kelkar both kind of described about the a little bit of background, so I'll tell you that for the last almost a month now, we've been having weekly meetings with the Joint Working Group for the World Academic Council of Emergency Medicine, where people from all over the world are sharing the knowledge that they have about the disease, and people from Japan, from Italy, from India, from the United States, and are pretty much giving their first-hand experience. And that's really been helpful for us to really learn from each other's experiences on how the disease has been progressing, and implement some of the changes either at the local institutions or share information through our weekly meetings. So what we have really I'll summarize some of the discussions that we've had over the last several weeks. We have noticed that a lot of the patients who are coming into the emergency department or the clinic sometimes have very typical flu-like symptoms, and early on in the evolution of this pandemic, most of these patients were getting tested only for flu, or in pediatric population getting tested for flu, strep, and RSV. But what was missing out was that all of these patients could have potentially had a co-infection as well. So a study that was published out of Stanford University probably 2 weeks ago discussed that co-infection was something they were noticing in a lot of these patients. The guidelines early on said that do not test for COVID if you had a patient who was positive for flu, but later on they started saying that co-infection was coming out. And at this point of time, if people have high risk factors, then we are pretty much testing for influenza, we're testing for strep, and we're testing for COVID as well. So what are the symptoms that we are really looking for in triaging our patients? So we look for, first of all, we get like travel history. So now that there's been community spread, and as Dr. Galvankar was saying earlier, the disease is existing in the community. It's either we are testing or we're not testing, but it's already at a state where pretty much the disease exists in every community. So things that we look for are travel history. And then other things we look for in the clinical picture is if they have tachypnea, or if they have tachycardia, if they have fever, and all the flu-like symptoms like malaise. And these are all, typical with the viral URI that you can get. But along with that, a lot of extrapulmonary symptoms are also being noted. The most common symptom extrapulmonary finding that has been noticed is actually diarrhea has been very commonly second system manifestation, organ system manifestation in these patients. And if patients have comorbidities, like for example, they have diabetes, then worsening of their comorbidities. So for example, diabetes, patients are coming in DKA, and or they're coming in HHS. So over the last several days, when I've been working in the emergency department, I've seen presentations of patients in DKA, which was precipitated from their viral infection, which is a very common reason for DKAs to precipitate or decompensate. And then patients with history of COPD are having exacerbations of COPD, and for such patients, the reserve is very little, and they decompensate really quickly. Then patients who have history of seizures, sometimes presenting with seizures at the time of arrival to the emergency department, and so on and so forth with other comorbidities. Basically, worsening of their existing diseases doesn't mean that that's all they had. They really could be having an underlying COVID-19 infection. So testing for that becomes even vital in these patients. Then comes when patients present to the triage in an emergency department. So I'll talk about how we do triaging for emergency departments in a little bit of detail, and then I'll give some overview on how places outside of the emergency department are handling this situation. So before patients started to come to the emergency department and testing in emergency departments were made available, a very clear announcement nationwide was done for pretty much every community that emergency departments should not be misused or overused just for COVID-19 testing, because worst case, if you don't have it, you may end up just picking it up from the emergency department visit. So this did not really come into effect or in practice when California was getting affected, because a lot of patients who were being brought back to the United States from China were being taken to, initially was planned to take them to LA, but then they started going to San Francisco. So a lot of really wide and rapid spread started happening in the community in San Francisco. But eventually, as more and more cities were getting involved and getting affected, tents were being set up locally and information about tents was provided. So what really happens is outside of the emergency department, as patients walk up, they go through a check-in desk from where they give their symptomatology, and they talk about their tachycardia, hypoxia, tachypnea, whatever they're having. They talk about that, and then after that, everyone gets a mask. That's the least that we're doing right now, is to provide a mask to all the patients. And then if they have any hard signs, they get placed in the tent for further screening, and then for the rest of the patients, they put their mask on and they go back into the regular waiting room for the emergency department. Now, as a healthcare personnel, could be a nurse practitioner, could be a nurse, or could be a physician, although most physicians are being utilized for triaging the sicker patients with telehealth service only, but patients then get a nurse practitioner or nurse to evaluate them and get the high risk points. And in particular, in our institution, what we're trying to implement now is, as what Dr. Sagar was mentioning earlier, was the different forms of hypoxia that these patients have. A lot of these patients they come in walking and talking and do not look like they're short of breath. But when you connect them to a pulse ox, they have what is called as a silent hypoxia. Then, so that's really like clear and evident, and these patients need an extensive workup with laboratories and with chest x-rays and maybe further imaging like CT scans to really figure out what the reason for hypoxia is. Then comes, in a lot of patients, for example, who have interstitial lung diseases, they tend to get hypoxic when they're introduced to some stress. So for example, if patients take 10-20 steps in the tent and they start to turn hypoxic, even that should alarm for triggering further workup and triaging of these patients as potentially high-risk patients for being infected with COVID-19 becomes important. So pretty much from there on, the higher risk category patients eventually get taken to a separate room zone in the ED where most of the COVID-19 patients are being evaluated. And the nurses that are taking care of these patients have really strict training on how they're donning and doffing. And people who are walking into the room, they're getting all the information about a potential risk or potential exposure from these patients. So the kind of two important terms to know is the silent hypoxia that these patients can have and the stress hypoxia. So a lot of these patients who are coming to get evaluated, they are patients under investigation, but they're not diagnosed. So till they get diagnosed, we can't really say what they have till we get the results back, right? So the results, typically when we started testing in Alabama, we were getting a 1-day turnaround time, but it went on to almost like getting the results back in 5 days, which in all honesty doesn't really change much for all the people who are coming in contact and was leading to a lot of admissions just to be placing them in the hospital for hypoxia and waiting for their results to come back. But over time, now we have implemented a rapid testing for a rapid PCR, which is giving us results back somewhere within the range of 8 hours to 12 hours. And by the early part of next week, we'll also be having antibody testing. And once the antibody testing and the rapid PCR starts, I think that will really help us in triaging our patients more efficiently. And so antibody testing, the claims are that if the patient is positive and they have antibodies, then, and their history kind of correlates, they've had symptoms over the last few days, and it basically tells us that they actually are carrying the disease, and they can further get PCR testing done.
Sure.
With this, I'm going to wrap up my talk and on how we are doing our triaging, and I'm going to pass on to Dr. Manish Garg.
Yeah. Thank you. Next speaker is Dr. Manish Garg, Program Director for Emergency Medicine Residency Program, Weill Cornell Medicine and Columbia University, Wiggles College of Physician Surgeons, New York Presbyterian Department of Emergency Medicine. Dr. Manish Garg will be speaking about COVID shock from Hot Zone. Dear Dr. Garg, please go ahead, sir.
Yeah, I wanted to start off by thanking API and also thanking Dr. Sudhakar, Dr. Kara, Dr. Galwankar for this opportunity. Just acknowledge my fellow speakers, and also my parents are on the line too. My mother's been a lifelong member of API, so appreciate that. Dr. Galwankar asked me today to talk about the hot zone. So I'm in New York City, both at Cornell and Columbia. We have over 2,400 positive COVID patients that are inpatient presently, 650 of which are COVID positive and in the ICU. And most of the patients that are in the ICU are on ventilators. When I'm working in the emergency department, I feel literally as though I'm running an ICU in my emergency department. There's probably, depending on the zone that I'm working in, I might be intubating, or having intubations done 2 to 3 times per shift. Sadly, my last 2 shifts, we've been pronouncing 1 to 2 patients dead per shift. And we have about 5 to 10 intubated patients on pressors while we were working. So if you look at New York City and you're looking at the fatalities that are there, what's really interesting, this is from data from 3 days ago, about 25,000 plus are in the 18 to 44 category, 23,000 plus in the 45 to 64 category. And those folks that are 65 or older probably represent about 14 or 15,000. So definitely much more in the younger folks who are transmitting. But if you look by the deaths in that 18 to 44 year group in New York City is only about 140, but the deaths in the 75-year-old and up are 1,130. So this is definitely a disease process that is affecting all age groups, but it seems like the young folks are transmitting it to the older folks. So how does the shock happen? Well, we talked about it. If I use 3 big categories, I can talk about it with respect to sepsis, respiratory, and cardiovascular. So, with sepsis, we have the systemic inflammatory response syndrome. We know that the source is this combination of all the symptoms that were described by my colleagues. The patient's tachycardic, the patient's hypoxic, elevated respiratory rate. So they fit all the SIRS criteria. When you start doing imaging, or if you do this stress hypoxia or silent hypoxia, you'll end up seeing that the patient will have viral pneumonia. Originally, when we first started culturing these folks with just the viral pneumonia bilateral infiltrate picture, we didn't find coexisting bacterial pneumonia. However, if they ended up getting intubated and then later on ventilated, they may then have superimposed bacterial pneumonia. And we've found that the procalcitonin is at times helpful for that. Unfortunately, these folks can go on to multi-system organ failure, and we especially see kidney failure as one of the problems on the sepsis part of shock. From the respiratory shock, we've talked about the silent hypoxia. That leads to adult respiratory distress syndrome, ARDS. And then we're seeing pulmonary infarction as a piece of that too. So you have to include all of those different components in the respiratory shock algorithm. And then on the cardiovascular side, we're seeing cardiomyopathy, we're seeing myocarditis, and we're seeing acute coronary syndrome. I've had multiple patients come in that were having what looked like a STEMI, ST elevation MI, and then sure enough, they also developed a fever. And when we did a bedside ultrasound, you could see that there was a decreased EF, and this is all coming from COVID. So septic, respiratory, and cardiovascular. So let's take a look at the international critical data. If you were to summarize the data from China, Italy, and Washington State, you'd find that the overall mortality is somewhere between 50 to 80%. ARDS is very common. In some of the studies that were there that I'll break down, it was up to 100%. Agent organ dysfunction were a real problem as comorbidities. And so we saw acute kidney injury and diabetes mellitus as 2 really bad risk factors. The average time to death in a lot of the patients that are coming in are 7 to 10 days. So if we break down some of the individual studies, when they looked at the Wuhan experience, 52 critically ill patients, this was in the Lancet, they found that 81% had 81% mortality there, 86% developed ARDS, and risk factors for death included, like I mentioned before, the acute kidney injury, and then about 30% had cardiac injury. So you can see that there's multi-systems of organs that are involved. If you had chronic risk factors, it included cerebrovascular disease and diabetes mellitus in this Wuhan population. The median time to death there was 7 days. In the other Wuhan that was in a JAMA article from Wu et al., they looked at progression to ARDS, and it included folks that were in the older age group. And what we were seeing, and this was referred to, we're seeing neutrophilia and a decreased lymphocyte count. And if you see those different pieces, that's suggestive to us that you're going to have COVID. And you're seeing organ and coagulation dysfunction. So it was mentioned by my infectious disease colleague, you see the higher LDH, and you see this D-dimer that tends to persist, which suggests that you could end up leading to having a coagulopathy later on. When you started looking at the Washington folks in the state of Washington, that was published in JAMA in mid-March. They had ARDS in 100% of their patients. About half of their patients developed ARDS by 72 hours. They used vasopressors in almost all of those patients, and that's been my experience as well. And in half of the patients, cardiomyopathy developed, which is pretty crazy, again, that you're seeing all of these different components of shock. And then in the another Washington State article, this was a New England Journal article from Bhattacharya et al., and they found a mortality of 50%. And their shock in that group showed about 71% of the patients. So shock is a real component, and this is what's leading to the advanced mortality. So how do we go about managing this? Well, one of the things that they looked at was they had the Surviving Sepsis Campaign folks take a look at this under the management of critically ill patients with COVID. And they had a couple recommendations for us. So one of the recommendations for acute resuscitation was if you measure dynamic principles to assess fluid responsiveness. So I think this is important. If you do use ultrasounds to look at the IVC, you have to watch out how much invasive procedures you do, but if you were to monitor CVPs, you might get an idea for that. But I think the better thing is to do non-invasive testing. They want you to do a conservative fluid administration strategy. So unlike normal sepsis where we might give 30 cc's per kilogram of crystalloid, they want you to start off slow, maybe 5 to 10 cc's per kilogram, because what we're finding is these patients get into fluid overload and pulmonary edema pretty quickly. They prefer you to use balanced crystalloids, so something more like lactated ringers as opposed to normal saline. And they'd like crystalloids over colloids. Some more recommendations that they had were that for adults with shock, they would like to use norepinephrine as the first line vasoactive. And if you don't have norepinephrine, you can use vasopressin or epi. Personally, I use norepinephrine and I add vasopressin onto it. And if I need a third pressor, then I'll go to epi there. We do not recommend dopamine, and dopamine can lead to arrhythmogenicity. And if these patients are having MI, dopamine becomes a potential risk there. And adding vasopressin can help if you target the mean arterial pressure to about 60 to 65. And one of the things that's important when you're thinking about the big picture here is looking at CPR and eCPR. So when you look at the American Heart Association guidelines, there's not really prescriptive data there. They're not telling you how to manage. They're more talking to you about, well, you want to make sure that you're in a negative pressure room. You want to limit the amount of folks that are involved in the process. Ideally, when you have the person who's doing intubation, it's a singular person, most experienced person using video laryngoscopy, also wearing a N95 mask with goggles, with potentially a welder shield, with covers to the hair, a fluid-resistant gown, and then that's the person who should be doing the intubation. We've even looked into getting these boxes, these intubation boxes, so you're limiting the amount of aerosolized, aerosolization of the COVID as it comes up. With regards to CPR, though, I'll tell you in real practice, we are trying to cover the patients in plastic to reduce some of the risk to the providers. We're essentially decontaminating the entire room. Every piece of equipment that we have ends up getting discarded. And then, you really need to, when you look at the data that's out there right now, there's not a lot of good neurologic outcome in patients that have a cardiac arrest because of this multi-system organ failure. So CPR is generally unlikely to be a benefit unless it's a select population, maybe very, very young with a lot of with very few risk factors. And similarly, if you're going to consider eCPR or ECMO, you really should reserve that for very young patients with a reversible disease. And this has led to quite a lot of difficult conversations that we've had with patients and their families about end-of-life care, about involving palliative care early. It's been very, very difficult having so many patients die per shift and the aftermath of this disease. So with that said, I will hand the torch over to my colleague, Dr. Swaroop.
Dr. Sinha, are you in the line?
Yeah,
Oh, Dr. Sim,
Yeah,
sorry.
can you hear me?
yeah, go ahead, please.
Okay, the next speaker is Dr. Sweta Upadhyaya. Topic: ventilating critical COVID ARDS in internal medicine, geriatric and pulmonary and critical care specialist, Bristol, Connecticut. Dr. Upadhyaya.
Yes. Hi. Thank you for having me. As my former colleagues and previous speakers have mentioned different dimensions of COVID infection, I'm going to briefly focus on ventilator or ventilation in ICU part. As we all know, COVID is a respiratory virus, and one of the major morbidity and mortality is from acute viral pneumonitis causing ARDS and then acute respiratory failure and also sepsis. So we get different flavors of this virus while taking care of patients in ICU. So based on the current data, and the data is very fluid, keeps on changing every day, if not every hour, up to 20% of patients infected with infection develop severe disease requiring hospitalization. And out of those patient population, about 10 patients of those infected patient gets admitted for a variety of reasons.
Dr. Upadhyaya, can you put your mic close to you?
Oh, yes, I'm sorry about that.
Not clear. Thank you.
Yeah. So I'm going to divide respiratory failure patients in ICU. One branch would be like non-intubated patient, another would be intubated patient. So in non-intubated patient, the goal of oxygen saturation should be above 90%, 90 to 96%. And we can provide low flow oxygen to these patients up to like 6 liters per minute. Again, higher flow rate has higher risk of spreading infection with a higher particulate size, higher air fermentation. So that's low flow oxygen. If patients are not doing well on low flow oxygen, then we switch to high flow oxygen, again in non-intubated patients. So how do we do it? It's very debatable at this point, but given limited data and limited resources, there are two options. One option would be providing patients with high flow oxygen if they can tolerate, and the second option would be non-invasive ventilation. That being said, if we decide to give high flow oxygen to patient, then lowest effective rate should be initiated. Recommendation is 20 liters per minute, 40% of IO2. Can you all hear me?
No, it's very weird. It's very dull.
Okay, I'm sorry about that. Let me just bring my closer. So high flow oxygen, as I said, lowest effective rate, 20 liters per minute and 40% of IO2. And if, and the patient that would kind of will do okay would be younger patient with not significant other comorbidities like other prior speakers have mentioned, diabetes, renal disease, cardiac disease. So we have to be very selective in choosing patients that we would decide to continue with high flow oxygen or non-invasive ventilation. They need to be monitored very closely. They should be ideally brought to ICU and decide, look ABG, look at them very closely. And then if they are not doing well, then proceeding to intubation would be the next step. What are the indications for intubations? As we all are kind of familiar with it, I'm just going to run over the list with you guys. Indications for intubation would be signs of respiratory distress, no brainer if patients are using accessory muscles or having abdominal bleeding. Rapid progression of disease would warrant patient intubation. If there is hemodynamic instability with multi-organ failure, I think we should proceed with intubation. And if the pH is less than 7.30 with PCO2 of greater than 50 millimeter mercury, patient should get intubation. As Dr. Garg had mentioned, intubation Again, video laryngoscopy is preferred to again reduce the risk of infection. If we decide to proceed with intubation and then the ventilation, what would be the mode that we should start patients on the ventilator? It's usually assist control with tidal volume of 6 ml per kg. Predicted body weight ranges between 4 to 8 based on ARSNet protocol. And also the recommendation is to start PEEP at 10 to 15 centimeter water pressure. And again, based on ARSNet protocol, titrate FiO2 and PEEP based on patient's condition. And of course, we should maintain plateau pressure less than 30 centimeter water pressure to avoid more trauma to lungs. Permissive hypercapnia is allowed. pH anything above 7.15 would be acceptable in these patients. And these are again guidelines from ARSNet. If patients are not doing well on these assist control, low tidal volume ventilation with less than 6 ml per kg predicted body weight, then a prone ventilation should be considered. Early proning is recommended between 12 to 16 hours per day. Before we were proning patients who were intubated, and now we are even proning non-intubated patients if they can tolerate that. If prone ventilation does not improve patient's oxygenation, ventilation, then we can attempt recruitment maneuvers. Again, intensivists are very familiar with these procedures and maneuvers. So recruitment maneuver would be the next thing to attempt. And if patient fails and if patients are not improving, of course, we can use neuromuscular blockade for ventilation or refractory hypoxemia. Inhaled pulmonary resuscitation can be used. And if all the above measure fails, then the last attempt would be trying ECMO. But again, with limited resources and poor outcome in these patients, we have to be very selective in choosing patients that would benefit from ECMO. That being said, I'll take some questions afterward.
Hello?
Yes, can you hear me?
Yes. Yeah, Dr. Upadhyay, Sweta?
Yes.
Okay. Yeah, are you done or you still have some more to?
No, I'm done. I'm done with my presentation.
Okay. The next presenter is Dr. Shailendra Upadhyay, the child, the adolescent, and the heart. Dr. Shailendra Upadhyay, please.
Hi there, good evening. Can you hear me? Hi, can you hear me? Am I audible or no?
Yeah, we can hear you. I just want to say a little bit more about you. You're medical director, pediatric cardiology and adult congenital heart disease in Connecticut Children's University of Connecticut School, Stamford, Connecticut. Okay, Dr. Upadhyay, please go ahead.
Thank you, Dr. Janalekar, and also Dr. Galvankar for organizing this. It's a pleasure and honor. Also want to thank Dr. Sinha. So, as we have already talked about, that it is quite dynamic. The data is pretty much evolving on a day-to-day basis. And what we speak or talk about today is going to be different tomorrow. I'm going to talk briefly about the and then I'm going to talk it will be a little bit of a few topics on pediatrics and COVID patients. So acute cardiac injury in COVID-19 patients, how do we define it? The definition differs in studies and is often non-specific. Most recent studies define it as if you see an increase in troponin levels about the 99th percentile. And in the previous studies, they suggested if you see an abnormal ECG or echocardiographic findings, that would be sufficient. But now we have learned that it also causes myocarditis, and those features may not be sufficient. And why is it important to know about cardiac injury in these patients and what's the incidence? The incidence is about 7 to 22% in hospitalized patients.
Dr. Pranapach, your spouse, can she mute her phone?
Yes, our phone is muted.
Yeah, go ahead. Thank you.
I can try and speak from a little bit.
Go ahead. Thank you. Go ahead. Sorry.
So the incidence of acute cardiac injury in COVID-19 patients ranges from 7 to 22% from various studies, most of which come out of China. And it's also associated with a high mortality. If you have a cardiac involvement in the setting of your risk of mortality is 42% versus 15% without COVID. And we all are familiar with the high risk factors in COVID-19 patients. If you're older, above 55, if you have a pre-existing pulmonary disease, diabetes, hypertension, cardiovascular disease, and if you're on biologic agents, if you have undergone transplant, and if you have HIV and your viral load for the CD4 count is less than and at presentation, if you have tachypnea, your respiratory rate is more than 24, you're tachycardic with a heart rate of about 125, on ambient air, they put you in the high risk category. And there's some lab things that are China as well. D-dimer about 1,000. CPKs are high, twice above the normal limit. The CRP is above 100, and on admission, if your absolute lymphocyte count was below 0.8, you have high LDH, or your troponins are elevated, or if you have high ferritin. What's the pathophysiology of cardiac injury in COVID patients? Of course, we don't know what the exact mechanism is. There have been several proposed mechanisms. There's possible direct toxicity because of the viral invasion of the myocytes, myocarditis. You may have acute coronary syndrome.
Dr. Sinha, can you mute your?
I'm sorry?
No, go ahead, sir.
One can have acute coronary syndrome and demand ischemia. You may have stress cardiomyopathy, such as Takotsubo. You can have myocardial suppression in the setting of profound inflammatory response from cytokine storm. It can really affect the heart in various ways. It can, because of prothrombotic tendencies, you can develop acute coronary syndrome. You may develop heart failure if you have a pre-existing heart condition or EF, or as a consequence of developing myocarditis. You are also at risk for arrhythmias, which could be from myocardial inflammation, or it could be related to sepsis and the other abnormalities that occur in the setting of COVID. If you look at the time course and prognostic implications, the troponin rise and acute cardiac injury may be late manifestations of COVID-19. It seemed to, after about 14 days of being infected, if you're getting sicker, particularly with the respiratory illness, you start seeing an abrupt increase in the troponins. And among the non-survivors, you continue to see a steady rise in the troponins throughout the disease, especially from day 4 to day 22. Acute cardiac injury is also associated with ICU admissions and more mortality. Acute cardiac injury is higher in non-survivors, which may be as much as 59% versus survivors, where it's just 1%. Acute cardiac injury in ICU patients, they're more likely to be in the ICU if you have acute cardiac injury versus not be in the ICU. It's a good idea to call cardiologists if you see certain changes, as marked by the blood parameters or other parameters, and these would include that if you have elevated high sensitivity troponins, if you have any concerns for acute coronary syndrome, if you have new heart failure or new reduction in the left ventricular ejection fraction, if there are any concerns for myocarditis, if you're dealing with malignant or unstable arrhythmias, or if you have undifferentiated or suspected mixed cardiogenic shock where the mechanisms are not entirely clear. So what do we do in terms of testing when we encounter these patients? I think all patients who come in or become inpatients for COVID, it's a good idea to get a baseline high sensitivity troponin, pro and terminal BNP, and CK on admission. And in patients, if they are in the ICU, it's a good idea to check all these and follow these serially as needed. In all inpatients, it's not a bad idea to check their troponins pretty much every other day. And if the troponins demonstrate any elevation, you can obtain a 12-lead EKG. And if the 12-lead EKG also demonstrates concerns, different institutions have different practices. If you have a portable ultrasound, it's a good idea to utilize that to do what we call the point of care ultrasound, or POCUS, or POCUS, where you can look at the heart quickly and determine if the left ventricular ejection fraction of the right ventricular function is down. And if so, then you need to get a formal cardiology evaluation and probably a formal echocardiogram. Moving on to arrhythmias, which is another major component in this population, it may be seen anywhere from 17 to 44%, depending on where the patients are admitted. If they are admitted in inpatient, all kinds of arrhythmias not particularly teased out as to what they were, could be as much as 17%. And patients who were admitted to ICU, the risk of arrhythmias were much higher, 44% versus non-ICU, which was only about 7%. In one study from Wuhan, China, they demonstrated about 6% risk of arrhythmias in the setting of COVID. In terms of the workup, we obviously needed an EKG on them, get cardiac enzymes, and potentially an echocardiogram to make sure the myocardial depression is not occurring at the same time. And when we manage them, the management approach is more or less similar. Again, you have to choose antiarrhythmic medications based on what your underlying ejection fraction might be. What about acute coronary syndromes? We know there's a theoretical increased risk, and also the previous data from the SARS breakout in 2002, there's probably an increased risk of acute coronary syndromes in these patients. Patients with influenza tend to have as much as 6 times higher risk of ACS when they get admitted or they get sick. The workup is very similar to what you would do in any other patient, with the exception that you have to obviously take extra precautions in terms of the imaging modalities and stuff, so that we don't transmit the virus from person to person. A few words about pericarditis and myocarditis in this population. So myocarditis and pericarditis are potential manifestations of COVID, as we know. There was one case report published out of Texas where they demonstrated they treated the patient pretty much through the bus of the patient was treated with antivirals, with glucocorticoids and chloroquine, and they demonstrated the EF improved from 35 to 45%, and the patient did well. In terms of the workup, there's clearly no role for endomyocardial biopsy at this time, given the risks and the potential benefit you're going to have from that data. Cardiac MRI, you can determine if the patient needs one, but again, keep in mind if the patient is intubated or if they're going to need intubation for lack of cooperation and things like that, it may not be the best idea to do it. And management would be otherwise similar to managing any other heart failure patient. In terms of using medications such as steroids, NSAIDs, or colchicine, I guess you have to weigh in all the risks and benefits. People have tried to use steroids, although in the setting and previous studies from SARS patients, it demonstrated that there was more rapid replication of the virus when you use steroids, and the benefits may be questionable. Similar thing with the NSAIDs, there are reports that they may be actually harmful rather than beneficial. So I guess you have to use your judgment and utilize these medications based on other associated factors of the patient. Some treatment things related to cardiology, so I'm not really going to talk much about the chloroquine, the hydroxychloroquine, and antivirals and all that stuff. I leave that to our infectious disease colleagues and President Trump. But statins may have a potential role for these patients. In what has been demonstrated in previous SARS patients and also with COVID patients is that they have an increased expression or overexpression of MYD88, which a gene which is responsible for kind of flaming the inflammatory cascade, and statins may have a potential role to inhibit that and suppress the inflammation. The other really important thing in patients who are being treated with chloroquine, hydroxychloroquine, or azithromycin is keeping an eye on the QTCs. And the QTCs can get long and then can lead to cardiac deaths rather than helping these patients. So it's really important when we start these, we pay attention to certain things. And there's something called the Tisdale score, where we look at various factors such as age, sex, electrolytes, some of the risk factors, and we come up with a scoring system. And score above 11, your risk of arrhythmias is high and it may be best avoided. Different institutions have their own protocols as to what to do. And when you start chloroquine, how closely would you monitor them? And so one should follow the institutional guidelines for those things. There are also questions come up about using the renin-angiotensin-aldosterone system blockers such as ACE and ARBs. Again, there's a theoretical risk that the ACE2 receptor is utilized by the coronavirus to enter the cells. And it may lead to, if you are on these blockers, you may have an increased expression of the ACE2 receptors. So there was a lot of controversy initially whether it should be discontinued or not. As of now, the ACC and AHA recommend that there's no strong evidence that these worsen outcomes, so they still recommend to continue it if the patients are already receiving this. A few words about COVID in children. Like any other disease, COVID can also be seen in pediatric population. The prevalence based on studies from China and reports that came out of New York, say that it ranges anywhere between 1% and 5% of all the cases. The signs and symptoms are usually mild in pediatric patients, and most of the study that came out of China demonstrated that median age of affected individuals was 7 years, and they saw more males than females being affected. Again, 171 patients in Wuhan, what they found was 55% of the kids were with had mild symptoms or no symptoms. 40% had moderate symptoms, and 5% had severe symptoms, and less than 1% had really any critical symptoms at all. One important thing with the pediatric population is at times they may present predominantly with GI symptoms. So if you have a kid who may not have upper respiratory symptoms but has diarrhea and things like that, it's likely that they have COVID if they meet the criteria. Otherwise, such as contacts and things like that, or if you don't have any obvious explanations for their GI symptoms, and they may also be asymptomatic carriers, and the COVID may also be released in the stool. So there may be some risk of fecal-oral transmission as well. Are children at risk of having severe COVID-19? Well, the answer is yes, it's rare, but it does happen, particularly infants that are below 1 year of age. As much as 10 to 11% can have severe or critical illness. And obviously they have pre-existing conditions, post-transplant or other medical comorbidities with COPD or related to any of the primary pulmonary issues. They can have a more severe course. I just wanted to talk briefly about the cytokine storm. The cytokine profile in these patients resembles similar to the secondary hemophagocytic lymphocytic propagation, and there's increased levels of interleukin-2, interleukin-7, and many other inflammatory markers that may that kind of lead to the probable eventual mortality of the patient. The Wuhan study also showed that patients who had high ferritins, had elevated interleukin-6 levels, were the ones that progressed rapidly into morbidity, worsening morbidity or mortality. It all suggests that a lot of this is virally driven hyperinflammation rather than the primary virus itself. In kids, we see some somewhat less pronounced immune response, and while the exact mechanisms are not known, but there are a few things that are proposed that they have less rigorous immune response. The cytokine storm that you see in these cohort of patients is less intense. There's also data that the viral interference in the respiratory tract of young children leads to lower viral load. And lastly, the receptors for the SARS-CoV-2 virus is the angiotensin converting enzyme 2 receptor, which is expressed differently in the pediatric or the young children. I think that's all I have. Happy to take any questions in the end.
Okay. Next speaker, Dr. Dr. Kanadi?
Yeah, next speaker. All right, let's.
Hello? Can you hear me?
Yes, sir. Go ahead.
Yeah, then the next speaker is Dr. Mamta Swarup, surgeon and the COVID pandemic director, Center for Global Surgery, Institute for Global Health, Division of Trauma and Critical Care, Northwestern University, Chicago, Illinois. Dr. Swarup, please go ahead.
Have you unmuted her?
Yes.
She's muted.
Oh, there we go.
Yeah.
So good evening, everybody. Thank you to API for hosting this webinar. And Sagar, thank you so much for allowing me the honor to be the last speaker for tonight. Probably the most enjoyable part of this epidemic, if there could be one, was the spoofs of some of the songs, both Hindi and English, that have come about. So just to, kind of relax everyone for a second, I just thought I would throw that out there. And if I can find it, I will find it by the end of this call, or the end of my 5 minutes. So, when we think about the surgeon, right, I'm not only a trauma and acute care surgery surgeon, I'm also an intensivist. And as I was introduced, I run a Center for Global Surgery. And so I mentor quite a few students, and I support them, whether they are in Peru, India, Pakistan, New York, Cambodia, or in Africa. And in addition to all of that, I am also the Chief Medical Officer of an impact investment fund. So when we think about what is a surgeon, it's a very interesting conundrum. So as a surgeon, we have an interesting role as trauma and critical care surgeons. First and foremost, as we prepared for COVID, what we wanted to do was be able to set clear goals for our patients, for their families, and for our colleagues. We also wanted to make sure the capacity for each hospital was, appropriately allocated, whether that was the ability for patients to get trauma capacity, trauma capabilities, and emergency surgery capabilities, but also definitively be able to have capacity to do COVID care. And what was really, seen is that many of the surgical patients that were presenting, let's say you have a case of appendicitis, you would catch the bottoms of the lungs, and many of these patients were silent COVID carriers. And so as data came in from Italy and from Spain and from Wuhan, what we were finding is that as we were, getting to the point of doing emergency operations for our patients, right? For any of our patients who were going to get emergency operations, the recommendations coming out of Italy, right, was that we should get a thoracic CT scan, right, regardless of if they were, even if we did not suspect them to have COVID. So if we knew that they had COVID, then they would go to a dedicated COVID operating room. But if they what do you call it, didn't have that, then they would have a CT scan. And these were the recommendations, again, like I said, that were coming out of Italy. And so taking all of these things into consideration and how are we going to do this and what are we going to do, what we came up with through the American College of Surgeons and at Northwestern, the way that our protocols came about is that instead of, having resource allocation, we just decided to treat every patient who comes to our operating room as if they have COVID. And that way we are careful with every single patient. It's just like if any patient is to have, when you're, bovying somebody or when you're doing a scalpel dissection or whatnot, you want to make sure that you are, having appropriate abilities. So you have universal COVID care, right? Is a way you could think of it. So in the operating rooms, we have negative pressure ORs with high rates of air exchange. We also have that a particular airflow within our operating rooms, which minimizes the risk of infections, and very specific ways that patients and operating room personnel come in and come out of the operating room. And everything that is disposable is very specifically and particularly disposed off, okay? And the things that need to be cleaned are very specifically cleaned as well, okay? We tend to have very minimal clinical documentation. We have a very specific protocol of how to clean not only the operating room, the equipment, the ventilators, and there's these very paranoid checklists, right? So, we tend to be checklist-oriented humans anyway. Now, the second part of what I do is that I'm also an intensivist. And so the things that we have seen and from around the world, the data that we have gathered amongst our group of trauma critical care surgeons is that my abilities are only as good as the things that I'm able to take care of. So for example, right now, the only things that I'm doing at the hospital are trauma and critical care. My general surgery duties have been shifted off to other general surgeons who are no longer doing elective general surgery. There are other surgeons taking care of those things. I'm running the surgical intensive care unit and a trauma service, and that's what we're doing for right now. We have one person who does that during the day, another person who's doing that all night, and then we have a third partner who is running one team of the COVID unit. So we're able to also take care of ICU patients. So what's been so interesting, as my colleagues have all spoken about, is this amazing hypoxemia, right? But with this really great compliance, right? Now, this great compliance is awesome, except they freaking need PEEP. This PEEP need is amazing. And so there's been documented video of a patient who's on 100% non-rebreather. You prone them and you watch their saturations go up. And we would love to be able to give them, as our ventilator, our ICU intensivist spoke to us earlier about non-invasive pulmonary positive pressure ventilation and high flow. But we can't because of aerosolization of the virus, right? And that's bad. That's super bad, because that not only puts the patient or, the the nurses, et cetera, at risk, that just kind of makes it go everywhere, no matter how much negative pressure we have going on. So to quickly go through a couple of other things, okay? Going from being a surgeon and an intensivist, the other things that I've been able to do when I'm not trying to be at the hospital is mentor, support, and innovate. So as we were talking about not having an antibody test, that's an at-home antibody test, one of the things that I do is look at tests and evaluate them. So we actually have an antibody test that you can take at home, and we're getting it validated by the FDA, or for the FDA, okay? And hopefully, as soon as it passes the FDA validation process, we'll be able to have people be able to go to their local Walgreens, pick up a test, and take it at home, and be able to have a schedule of being able to take it, which is pretty amazing, right? Especially with the magnitude of how you can, you know, produce and manufacture these things. Additionally, right, you know, oftentimes surgeons want to do things, right? And everybody wants to help each other. Everyone wants to take a role and be a part of something, be a part of a movement, right? You guys are on here listening, trying to figure out how to protect yourselves, how to protect your family, and what are the best things for your patients to be able to do. But part of that starts, one, from knowing where the resources are for the first place. And the second thing is,
Dr. Saurabh, I think we had to wrap it up because we had to have some panel discussion. I apologize for the interruption.
Yeah, no worries. I just wanted to say one more thing, if that was okay.
Yeah, go ahead, please.
Can I have 30 seconds more?
Yes, please.
Oh, okay, great. So the second thing would be is how do you come together? So being able to mobilize multiple different groups of surgeons, emergency medicine doctors, radiologists, all together, bring them together with students, residents, and be able to move supplies from one region to another, and can have private sector work with physicians, work with students, and make a resource is the other way that we've been trying to all come together to be able to bring PPEs to one another. I think I stayed at 6 minutes, so I thought I was doing okay.
Thank you. Thank you. Dr. Sagar Galwankar, are you on the line?
Yeah, so thank you everyone.
Yeah,
I think we went over time, but I think there was so much data to be covered. If you can see the journey of the patient, I'll just wrap up by saying a couple of things. The key take-home points is the aggressive, which I call the HIT protocol, that is high intensive tracking of the history. So you got to hit the patient with the history taking skills to get all the data from the patient, recognition of silent hypoxia and stress hypoxia, know very well what you're going to test and who are you going to test and what is the test at hand. Because we got to realize one thing, a tool with a fool or a fool with a tool is still a fool. So you got to understand random testing is not the answer once we are there and located in the situation of whom to test, what to do with the test, and how to proceed. You realize that the triage scenarios are very important. I would like to tell the group that MD Cal has come up with a new COVID system for scoring. Please look that up. MD Cal has something called as a Brasilia COVID respiratory scale called BRICS, BCRSS. At MD Cal, it is freely available. So that helps you in the triage system. Who do you intubate? So low flow, high flow intubation, but nealizing, aerosolization is the issue. Who do you give DNR? Who do you intubate? How do you intubate? Do you do prone? Do you do non-prone? The difficulty in weaning them off the ventilator. All these points are important when you treat them as sepsis and shock. Is it sepsis? It is cardiac? Is it respiratory? You got to realize there is a thin line or a very small path between respiratory shock and cardiogenic failure. Very thin path because it's not pediatrics. We spoke about the various complications of medications on the cardiac system and the incidence of pulmonary and extrapulmonary features with the predominance of the cardiac system and the GI system. So you got to think about those parts when you are giving inotropes, where dopamine is not recommended. Start with non-ep, go to ep last. So here we are with the whole compendium of going ahead and managing a patient. And we do realize that there's a lot of challenges and a dynamic data about PPEs. Many people want to know about steroids and hydroxychloroquine empiric treatment. So I think those are the questions we focus on. But what we have tried to present to you is the journey of a patient directly from the clinic or the ER directly towards the end till discharge, and how teams come together. So try to bring to you all the aspects. Also, every weekend on Saturday morning, 9:30, there's a world call of all the experts who are published, who are really giving you the data. There is an update on what hot zone data we are gathering. That's where we came to know about thrombosis. That's where we came to about ruling out PE, the silent hypoxia, the stress hypoxia, hypokalemia, myocarditis, heart failure, and the procoagulant effects. So with this, I'll wrap this up from our part and open it to the panel. And I would like to call infectious disease, because those are the major questions which are coming up here, to comment on 4 things. Can we use steroids? What is the status of the hydroxychloroquine in today's therapeutic options? And what about the plasma therapy being tried by various institutions in a trial methodology or a life-saving measure? So if I...
Sagar, let's do one question at a time, please, not all together, jumble. That will be, thank you.
We can answer all those questions. So if we can get ID to comment on these 3 things, a lot of questions will be answered.
Excellent, thank you.
Hello?
Yeah, please.
Yeah, can you hear me? Yeah, this is Dr. Kelkar. So let me start with your first question. The number 1 question most people have on their mind is the role of hydroxychloroquine. Now, there were some studies, again, small non-randomized trials, and then one small randomized trial, which initial part showed from China that hydroxychloroquine decreased the viral load in patients. The respiratory viral load was decreased because of using chloroquine. They used actually chloroquine, chloroquine was found to have some in vitro antiviral properties for SARS-1, the original SARS, and that's why they tried using chloroquine for this time. And because of that few non-randomized studies which came up and which did not even have a control group, everybody, started using chloroquine. Is this currently FDA approved? No. Has the FDA allowed emergency use of chloroquine if you want to use it in patients with COVID-19 and severe symptoms, so they don't, stop you from using it? They have had an emergency authorization where you can use it, but it's again still an unauthorized use, and you are supposed to use it with strict cardiac monitoring and making sure about all the side effects. Plus, does this actually have an effect or no? No, we don't really have the data. We don't have randomized controlled trials. Most patients who are looking at the news and looking at all, not just news from here, but news from China, from all over the world, will want it. So will you be able to tell a patient easily, saying that no, the world is, taking this therapy, I don't have data, and so I'm not going to give it to you? No, you can still, if the patient wants it, you can still offer it to the patient, you can still use it. But again, it is not still an authorized magic pill which is going to cure COVID-19. So current data is whatever the small trials have been only about 5 days worth of chloroquine. And in some patients they had used it in combination with azithromycin. So that was the question about chloroquine. And I will answer the question about steroids, but I think critical care can also chip in because they see these the outset. So as a recommendation, no steroids do not decrease the inflammation for these patients, and no steroids are not recommended. But if you have some other reason for using steroids, it should not stop you from using them.
Critical care, do you have a take on it?
Can you hear me?
Hello?
Yes,
Yeah.
Dr. Upadhyay there.
Yeah, can you hear me?
Yes, we can.
Yeah, I agree with my ID colleague that steroid again, everything is controversial, like management besides supportive care. So there is again no study that has shown to prove or improve outcome. If we need to use it for COPD exacerbations, asthma exacerbation, then we can go ahead and use steroid. But to use it for ARDS, it's not recommended by different societies. SCCM, JAMA article, it's in surviving guidelines from SCCM. It definitely does not recommend it. But if we have to use it for asthma and COPD exacerbation, we can use it. Again, if we have to use hydrocortisone with refractory septic shock, it is also up to 200 milligrams per day. It's recommended to use it, but not for ARDS causing acute hypoxemic respiratory failure.
This is Lokesh Idara. One question, one patient started our own HAPI member on hydrosteroid. University of Michigan protocol changed now. Is any experts can comment on adding steroid a little early? Salmeterol, I think 64 times a day or something like that. Can experts add comment on that protocol? Thank you.
Shweta?
Yeah, so if can you hear me?
Yeah, we can.
Yes.
Yeah, so in routinely what we are seeing in our ICUs, if patients are not improving after 5 and 10 days of following ARDSNet protocol, trying different modes of ventilation, then if they are getting into fibrotic stage of ARDS, then we have used steroid. Has that shown any improvement in outcome? Not in my experience. Other intensivists, I think Dr. Swarup can chip in as well. But again, initially based on the studies and the recommendation, again, with weak recommendation, it's not recommended to use initially.
Absolutely.
Hello.
Add
Hi.
We don't.
Hello.
Yeah.
We don't.
Can I add a question, Doctor? This is Dr. Sinha.
Yes, go ahead.
So this suppose the patient is already on hydrocortisone because of other diseases. There are some other disease patient has to stay on hydrocortisone and they get the COVID. How do you manage those patients?
You continue.
Do you have?
Yeah, if they were prior coming to hospital, if they were on steroid, the recommendation is to continue as outpatient or home dosage.
And the other thing, this hydrochloroquine is randomly being used all over community, all over places, without any science, without any clinical trials. Is it anybody has any idea? Is it helping anybody when the patient are severe disease? Any of you has heard that? Is it making any difference?
Can ID comment?
Yes, please, ID, please. So again, we actually have not had any any data come back saying that the chloroquine helps, because we have not been able to currently monitor how much the viral load, whether the viral load drops and whether it's significant and whether this is related to the drug. So it's a question whether or not this works is again a question. Whether it has side effects is, yes, there are definitely side effects, and if you don't monitor it, very closely, you will develop side effects with it. But whether it is of benefit or no is to be seen. it's a fluid situation. Maybe they are trying some trials, and maybe we might have some more data coming from that.
Okay, I got it.
While Dr. Another question came, the same on steroids, but this patient is a physician or a colleague and recovered 3 weeks positive, and she still have shortness of breath. The question is, can she use it like, I mean, she never been to the hospital, but she's at home, recovered well, but she still feels short of breath, mild but persistent. Albuterol inhaled didn't help. Can we try steroids or not? That's a question. Thank you, sir.
I would not recommend. I'm not sure if the chest X-ray was for that patient you are mentioning. If the chest X-ray had like abnormality, then it may take time for her to recover. But I would continue to. Again, there's no data based on our experience, anecdotal experience. I would recommend using inhaled short-acting SABA, short-acting agonist for symptomatic relief.
Her chest X-ray was normal.
Okay, so again, I would not recommend initiating ICS because they do have increased risk of pneumonia, so I would not recommend that.
Can I add a couple of points here?
Go ahead, sir.
So I need to humbly submit to the group a couple of things. First of all, you got to understand that the virus is aggressively attacking the body with pulmonary and extrapulmonary symptoms, number one. Secondly, if you are in an immunocompromised state, you're at risk, number two. Third, silent hypoxia is a reality. It's there. So catching silent hypoxia is very well key. Steroids is not going to cure the disease. So you got to be very proactive in ruling out silent hypoxia. Now there is a silent hypoxia algorithm which will be published by the end of this week. We are on the working group for it. A 100-page primer is coming out on COVID on everything available. So we'll put it free for y'all to read. We'll post it so y'all can get it. But a couple of things which have to be really clearly understood, that there is a pathway that if there is a normal X-ray but silent hypoxia or stress hypoxia, aggressive looking for a PE is being considered, or other causes of shortness of breath because of the thrombotic states, and they are working on the algorithms for that. So it's not only steroids, it's not a wonder drug. So we got to be very careful when we start giving medicines, when we start treating patients, the cardiac toxicities, recognition of clinical symptoms. And I understand majority of our members are office practice. So really taking those efforts at the office and making sure that you have isolation rooms in your PPEs is very, very important. So that's the fundamental of it. And yes, people are randomly taking chloroquine or asking for that. It has to be taken with the riders which are mentioned when you give Planquin or you give all the other medications. And anticoagulation has to be discussed with your primary care doctor, the risk about anticoagulation and all the things attached to that when you are chasing hypoxia with a normal X-ray. So please understand the whole compendium. And this has to be taken very seriously. And there are two types of patients: undiagnosed patients, diagnosed stable patients, and diagnosed deteriorating patients, and symptomatic patients who are not diagnosed. 4. So you got to play around those 4 and understand which category you're falling in or the patients are falling in. So I think that makes a lot of clarity and being very objective when you look at COVID. And I understand that everybody wants to hear good news, but as doctors, you got to be very objective, period. There is no compromise there. So, we got to do what we are trained to do. And yes, we want to hear the things we want to hear, but going really by the things is very, very important. And really, we shouldn't get into, oh, what should I do? Well, you're a doctor. So what the data says is what we have to follow. So I guess everybody, this puts everything clearly, and we could take questions on regards to other things related to that. And there's a question on Lovenox for D-dimer. Well, chasing silent hypoxia with a normal X-ray is a CAT scan next. And that's important. getting a bedside echo is important. And that algorithm will be out by the end of this week. Regardless of the fact, when patients are admitted, and if the creatinine is high, they still go on anticoagulation, which is adjusted. So the doctors are taking precautions to understand that there is a prothrombotic state which is being created by COVID.
Thank you, Sagar. Thank you. I have a question to the probably ID doctor, probably Dr. Kelkar. One of the doctors says, she took care of 3 COVID patients, healthcare workers. She used a Plaquenil, they got improved, but she's symptomatic, they improved well, but she asked, when they can safely return to work.
So when the patients can return to work, is that that's the question?
Yes.
So the health department currently still states, and the CDC still states initially that they want them to test negative, but before they can come off isolation. But the CDC has now changed some of its guidelines, saying that if a patient has been COVID tested positive, they needed 2 negative PCR tests for them to be able to come off isolation. If the patient had a COVID-like illness but was never tested, then you have to be 3 days fever-free without taking any antipyretics, and at least 3 days of no symptoms or marked symptom improvement before you can resume work. So that's the current guidelines. Now, even these guidelines are updated, quite frequently as more and more new data comes in. Like today, the CDC announced, like people who have been exposed don't necessarily have to stay out for 14 days that we initially thought that, okay, if you have been exposed and you're in healthcare, but they can self-monitor for symptoms and return back to work much earlier if they're not symptomatic. So these guidelines keep changing, but the current guideline was as per what the health department of that state or that county is following is what you would have to refer to.
Thank you. Dr. Lokesh?
I think I don't have any direct questions, so I think Sagar have all those on the chart he's covering.
Okay, good.
All right. Dr. Shweta and Dr. Kelkar, can you please comment on this plasma trial which is going on the use of plasma? Can we look at that? And we can get Shweta and Dhanashree's comments on that. Are you all there?
Sagar?
Yeah. Can they hear me? Are they there?
Yeah, I can hear you.
Yeah.
To be honest with you, we don't have a whole lot of familiarity with the plasma trial that's going on. The experience comes from China, where they used it in 5 patients, and 4 of them recovered, 1 died. Again, if you go by what CDC recommends right now, it can only be compassionate use, and you have to request it. You have to seek a special permission to give it to the patients because of all the risks that also are associated with giving plasma to patients. So that's all I know as of now.
Yeah, you're right. And
this is Dar. I'll just add one. We had got permission from Ohio governor to one of our colleague today, and 2 donors are there, and she getting tomorrow. So hopefully in a week we'll know, and more data will be coming out. Thank you.
I think one of the things that
but also one more thing on plasmapheresis. This is very controlled by the FDA, and they have a very strict criteria, and only certain centers are allowed to do this clinical trial. So it's not available in every hospitals and every places. One has to, this is an exceptional case that you're talking Ohio. I know about that case, but otherwise it's not widely available that anybody can do in any hospitals. It's under a very strict protocol and trial.
And one more to add is I just saw ICMR in India give permission to Kerala to start the health secretary approved for this plasma. Just now I saw on the blog. Thank you.
Okay. I agree with the points already stated that number one, yes, it is not FDA approved. it is only for trial and it is for compassionate use. So we don't really have that much data on it as yet.
Now, I want to bring to the group's notice that as of now, around 100+ trials are in action at various parts of the world. Some registered with CTRN, some were not registered, and multiple people are using multiple combinations and trying to find a cure for the for COVID. But at this time, I think our focus should be protecting ourselves rather than trying to gain knowledge, and got to be very proactive on the fact that staying home, staying safe, staying alive are very, very important. These are 3 important facts which I have learned because I was sick last week, and we tested negative. My wife tested negative for COVID, and it's very important to realize that our personal protection, at the same time, we're not missing diagnosis, is equally important. So I really think that keeping these facts in mind, we should be very proactive. And once the community spread has started, it's there in the community. So of course, like today, Dr. Murthy's article said that handshake will be a history very soon. We got to think about things like that, and things about sanitization, and things about protecting ourselves, our kids, and if we have high risk, like a lung disease, a transplant, diabetes, of course, we are going to be on the edge all the time. And that's where we are. And as doctors, we have to be very particular and not think that it's not going to happen in my backyard. Because pretty quick. So, I'm sorry for those who don't want to hear what they heard, but objectively speaking, everything is just to save lives. And all the medicines are being used and combinations are being used to save lives. And really speaking, there is no magic pill which is going to protect you other than the pill of PPE and self-precautions. I also, that's where we are. And it's very ironic that today is Hanuman Jayanti and is considered Sankat Mochan, and we are faced with this global Sankat. So it's going to be pretty hard in those coming few months to take over. As doctors, we got to focus on prevention and act front line. Our colleagues are working.
Yeah, thank you.
I want to add, I agree with you. I want to add one more thing, that we all have to realize as a physician that the life is not going to be the same like a pre-COVID. It's going to be changed. And we have to learn and teach everybody to change all the habits and how we have to live. It's going to be a long time, and it may not come back pre-COVID life. So that's what we have to accept that, and that's the truth, because we don't know what will work till we have a vaccine, and the vaccine, we'll see how that's going to pan out. Anybody has experience, or have you heard about this BCG that's going on in Germany? BCG.
No, there is
when we Indians has gotten BCG when we were growing up in India. Everybody has gotten that.
Sir, even India, sir, let me be very clear. Government of India, Chief Epidemic Officer, Dr. Ganga Khedkar, has totally clarified it has nothing to do for protecting COVID. Very clear. And
how? Has it done any
yesterday?
Antibodies test? How do they, any scientific basis that some people has?
Dr. Ganga Khedkar was very clear.
There is an Australian study in the way, and apparently it includes.
So currently, there is no clear data about number one, BCG-related antibodies didn't wane over a period of years, and after a period of 10 to 15 years, most of our antibody levels have gone. Whatever was produced by the BCG has gone down significantly. Secondly, the thought that, okay, BCG countries who have received BCG, whether they are not getting severe COVID illness. Now, some part of this thought may be related to the way the immune responses, the Th1, Th2 immune response, because most countries which receive BCG are lower socioeconomic countries where you have a number of parasitic and GI illnesses also, which are on an ongoing basis. So the immunity which they have generated is very different than westernized nations who do not receive TCT.
Right.
So it could be related to that, but we don't know that right now.
Yeah, that's not clear. I understand. I got it. Thank you.
Sagar, you have any questions on the chat, please?
Or any other
I think,
statements from others?
everybody wants to hear the same story about chloroquine being the wonder drug, and we don't have any wonderful answers for them. So that's all we have.
I have never ever treated patients blindly without science. We are doctors, we are science, we have evidence-based, we practice as evidence-based. So blindly treating anything without knowing whether it no harm, it doesn't matter. But I will not recommend to use unless we have a solid.
Thank you, Vinod. Right? I have a question on pulmonary, Dr. Upadhyay. Are you there?
Yes.
Yeah, the question is another pulmonologist question. What is the timing of tracheostomy on non-weaning ARDS patients?
Yeah, so again, there are multiple societies like from surgeons, ENT doctors, and intensivists. There is no clear guideline about when to do it, as we all know that patients who are getting intubated with ARDS are requiring longer time on ventilator, more than typical pneumonia or any other viral illnesses. Again, based on speaking to my other colleagues in New York and other rest of the country, they are recommending like after 10 days, if they're not improving or not able to wean, they are doing tracheostomy so that patients will be more comfortable, less sedation. But again, tracheostomy itself has increased risk of aerosolization, like up to 30%. So again, it's risk versus benefits, but there are people who are doing tracheostomy. Patients are not able to be weaned after like 10 days.
Okay, thank you. I have a question to the panel, actually. You have an experience of using Genentech drug Actemra and Gilead drug Remdesivir.
Okay. So I can speak about, so Remdesivir, we haven't really had a chance to use it as yet. But again, it is on clinical trial. I did have two colleagues of mine who were trying for using it in Texas, and they were still on back order, though they were approved. As far as Actemra goes, have used it on 3 patients so far. 2 of them have not really improved. The third one, we just used it yesterday, so I don't have the data. All 3 of them had a cytokine storm. Interleukin-6, which is the lab marker, which we are supposed to do before we use this, is not easily available to us, and we get the results only in 3 to 5 days. But so yes, we have used that because some of these patients have such a massive cytokine storm that we try to use Actemra for those. There are other antibody other trials, Nivolumab and other blockers ongoing at other sites currently.
Thank you. Vijay, can you open Dr. Reddy's, unmute Dr. Reddy?
Hello.
Dr. Reddy, is Dr. Suresh Reddy is the president of API. He's going to wrap up. Thank you.
Hello, can you all hear me?
Yeah.
Yeah. Thank you, everybody. Thank you for organizing this wonderful event session, one of our sessions, and heavily attended. Thank you, the moderators, Dr. Sudhakar Jonalagada, my number 2 in command, and Dr. Lokesh Idara, and Dr. Vinod Sinha, and my co-pilot, Dr. Seema Arora, Chair of BOT. And speakers, thank you for wonderful speakers, and Dr. Dhanashri Kelkar, Dr. Sharat Kalra, Dr. Manish Garg, Dr. Shweta Upadhyay, Dr. Shailendra Upadhyay, Dr. Mamta Swarup. Thank you for sharing your expertise and knowledge. And more than that, thank you, the audience, for joining and interacting and asking relevant questions. And I'm so impressed by all the audience, everybody. This is almost, I think, 10th or 12th session we are doing, and none of the sessions we have audience less than 200, and the maximum went up to 500. So I'm very impressed with the audience. Thank you so much. Thank you, speakers. Thank you, moderators and organizers. Thank you so much.
This is Lokesh. Thank you for Sagar Galwankar. He's the one who did all put together, and we really appreciated his leadership and putting the panel. Excellent. Thank you, sir.
Thank you, Sagar. I really appreciate it. Thank you very much.
Dr. Sudhakar, on the chat box, you can see that every Saturday there is a World Council meeting at 9:30 where the hot zones line up for latest trends of care. So if people want to attend, they could email me and I could send the invite, because it's an exclusive meeting of the investigators. But if people want to attend, colleagues want to attend, they're more than welcome. And I'm very thankful to API for requesting me to do this. It's been after a decade that I have come back and done something. So thank you very much, everybody. And Dr. Sudhakar especially, who worked very hard, including my speakers, who have put in nearly 18 to 19 hours organize this panel.
Oh, wow.
Thank you. Thanks a lot. Thank you very much. We really appreciate it.
Thank you, Sudhakar. Thank you, Sudhakar. You are the best. You are the best, Sudhakar.
Thank you, Binod. Thank you, Lokesh and Sagar and all the speakers.
Thank you. Good night.
Good night.
Good night. Good night.